In patients with advanced colon cancer, we know that patients who are microsatellite stable disease, the options are very limited. And we know that regorafenib and TAS-102 are available in those settings. Generally speaking, PD-1 blockade is ineffective in patients with microsatellite stable tumors in advanced colon cancer. However, last year at ASCO, and now this paper is also published in JCO as well, group from Japan presented the data where they combined regorafenib plus a checkpoint inhibitor, nivolumab, in patients with MSS, microsatellite stable advanced colorectal cancer. Now, we know that the rationale is that the regorafenib is a TKI that can actually reduce the tumor-associated macrophages by blocking the CSF factor 1 receptor, for example. And also, the regorafenib can block PD-L1 and ID1 expression while maintaining MHC1 expression. Therefore, by combining the regorafenib with nivolumab, it can potentially augment the anti-tumor activity. And the data that was published now, JCO, shows that by combining regorafenib and nivolumab in patients with microsatellite stable, granted these were all Japanese patients, the response rate was hovering around 30%. And the dose they recommended at that time was 80 milligrams of regorafenib with standard dose of nivolumab. So we conducted a very similar study. So this was a phase 1/phase 1b study of combination of nivolumab plus regorafenib. And in the phase 1 portion, we were dose escalating the regorafenib from 80 to 120 to 160 milligrams with a standard dose of nivolumab, followed by expanded cohort, which we're trying to get about a total of 40 patients in the expanded cohort. So at GI ESMO, we're presenting total of 28 patients, so 12 in phase 1 portion and 16 in the expanded cohort arm. And in the phase 1 portion, we had total 12 patients. We had 3 DLTs. The 3 DLTs were all rashes, 2 in 120 milligrams and 1 in 80 milligrams. So therefore, based on those dose-limiting toxicity, we felt that patients in the expanded cohort, the dose that we were using will be 80 milligrams of regorafenib versus plus a standard dose of nivolumab, which is very consistent and very similar to what the Japanese group recommended. However, the main difference between our study and the Japanese group is that in our study, the response rate from our study was only 5%. Out of 5%. And that was unconfirmed. And the stable disease was about 66%. So based on what we have so far, obviously there's a discrepancy between the group from Japan and from our group that the response rate was not quite there, up to 30%. Now, in response rate, the median PFS in our study was about 4.3 months, and the median overall survival was about 11 months, with only median follow-up about 5 months. So it is unclear exactly why there's a difference in the response rate. Obviously, it could be from the inclusion criteria. And obviously, there's some hypothesis that if you have metastatic disease to the lung, those patients may do better. If you have left-sided tumor, it may do better as well. Once again, these are just hypotheses generating by itself. So obviously, we are still enrolling this patient in the expanded cohort, and we're hoping that we'll get a total of 40 patients in the expanded cohort, so a total of 52 patients overall, which will hopefully be presented next year somewhere in one of the symposiums. In terms of the side effects, it is very similar to group in Japan, that the most common side effect that we've seen in this study was the rash, fatigue, and hand-foot skin reaction. And this includes 3 DLT that was related to rash as well. So right now, I think, the conclusion of our study was that obviously the trial is still occurring right now in the expanded cohort. We're hoping to have a total of 52 patients that we presented hopefully next year. So far, the response rate is very modest. At 5%. There may be a subgroup of patients, they may respond better than the other, but so far we haven't found that yet as a moment. But hopefully as we accrue more patients, we'll get more information on the subset that may benefit or not. And hopefully I will be able to present the data sometime next year.